as per your request, so we are going to do congenital radioulnar synostosis. Of course, a very important topic from the exam as well as clinic's point of view. However, it's going to be very, very rare. Okay. So what is basically radioulnar synostosis? Okay, so it means both the radius and ulna have become sort of one bone, and that's basically what it is about this entire talk. Okay, so it is basically an abnormal rigid connection between the proximal radius and ulna because of an erroneous embryological development. So what happens when both the radius and ulna have become sort of one single bone? It leads to a deficit in the forearm rotation. Okay, so that is basically the physical disability that these children or these adults present with. Okay, so this was first described in 1793, and to date, that's by 2021, when the last review article was written, the number of cases of congenital radioulnar synostosis amounts to somewhere around 616 cases only. So if you come across any case of congenital radioulnar synostosis, it is a very good case for a case report, or if you have many cases, you can write a case series about it. Okay, so let's talk about the embryology and genetics for a bit. So to understand the formation of the upper limb and why the radius and ulna have not differentiated into two different bones at all levels, we need to understand the multi-axial differentiation of the upper limb part. Now, as you know, the multi-axial differentiation, which happens in the embryonic life, is dependent on a lot of different proteins. And we'll not talk about all of these, but we have a few of them. That's the homeobox, the sonic hedgehog, the Wnt proteins, that's the wingless type, then the fibroblast growth factor, the FGFs, as well as the SOX protein. So these are a few of the proteins or growth factors which are involved in the multi-axial differentiation of upper limb bud. So we have the word called multi-axial, that means many axes. So what are the different axes? So we have three axes of development, and they are the proximal to distal axis, the ventral to dorsal axis, and the antero-posterior axis or the radioulnar axis. Okay, so what is the proximal distal axis? That means the limb grows along from the proximal end to the distal end. The ventral development is that there is a volar aspect and a dorsal aspect, and lastly, it is the radioulnar differentiation, which is where congenital radioulnar synostosis gets erroneous or error-filled. Okay. So for different developments, we have different proteins. Of course, there are different things called apical ectodermal ridge, the zone of polarizing activity, and all of these, which we will not delve into in a lot of, in a lot of this thing. So first we have apical ectodermal ridge. Okay, so that is the apical ectodermal ridge is going to lead to proximal to distal differentiation. And then you get the zone of polarizing activity, which will lead to both ventral dorsal as well as a little bit of the radioulnar differentiation. Okay, so because it gets polarized, so you have a preaxial part and a postaxial part, you have the two ends, that's a ventral part and the dorsal part. So these are the different axes. So if you see, the proximal to distal axis goes something like this. So if you have a limb bud on the left hand side, the limb bud tends to grow, it comes out. Okay. However, once it grows, the ventral to dorsal, as well as what stays up and what stays down, is not really segmented. It doesn't become separate. So instead of these two bones, you have a single bone here. So this is called failure of segmentation. Okay, so the problem with congenital radioulnar synostosis is a failure in the longitudinal segmentation of the two bones of the forearm. Okay, now genetic wise, initially it was thought that this is an autosomal dominant condition with variable penetrance, but now we know that there is no clear inheritance pattern. However, a few associated conditions along with congenital radioulnar synostosis are Poland syndrome, Holt-Oram syndrome, Cornelia de Lange syndrome, tetrasomy X, and Sinani-Lenz syndactyly. Okay, of course, these are not very important. And since you know that there are only 616 cases to date of congenital radioulnar synostosis in the literature, uh, and only about say 20 to 30% of them have associated conditions, you can think how rare it is to have a congenital radioulnar synostosis with an associated condition. Okay, now coming to the anatomy, we already talked about the failure in the longitudinal segmentation of the forearm bones. Okay, so we need to know where they do not separate. So the most common area where they don't separate is the proximal radioulnar joint. Okay, so the proximal radioulnar joint by itself is a synovial pivot joint. Okay, we are not talking about the elbow joint, not the humeroulnar joint. We're talking about the proximal radioulnar joint. So this is a synovial pivot joint. And by pivot, we mean that this pivot helps in the rotation of the forearm, that is the pronation and the supination movement. However, when the pronation and supination takes place, the radial head stays in one position. It does not go across the ulna. It stays in one position, and that position is stabilized by the annular ligament with association of radial collateral ligament, the lateral ulnar collateral ligament, and the accessory lateral collateral ligament. Okay, so the main ligament which keeps the radial head in place is the annular ligament. Okay, and of course, this articulation between the ulna and radius takes place between the radial notch of the ulna and the radial head itself. Okay, so the congenital radioulnar synostosis has the forearm fixed in varying degrees of pronation. Okay, now if there is limited motion which is present, then we call it a partial synostosis. But in most conditions, there is no movement which is present. And then it becomes a complete synostosis. Okay. The most common position of this synostosis is in maximal pronation. That means any pronation which is more than 60 degrees is the most common position of synostosis. The compensatory motion is often given by the shoulder and wrist to perform the activities of daily living. So imagine there is a wrist which is in 60 degrees of, or a forearm which is in 60 degrees of pronation. Now the patient might be able to pick up the food from the plate with 60 degrees of pronation, but may not be able to rotate the hand to get it till the mouth. So in this condition, the child will adduct the shoulder and externally rotate the shoulder in order to bring the forearm into a pseudo supination position. Okay, so these are called compensatory motions, which are given by both the shoulder and the wrist. Now you might be thinking that the wrist will be moving only in a dorsiflexion and volar flexion, as well as a radial deviation and ulnar deviation. Okay, but a wrist is such a joint that in conditions with congenital radioulnar synostosis, it becomes sort of a incomplete ball and socket joint, where even rotational movements of pronation and supination are possible. Okay, and those are the compensatory motions which are present in only in patients with this limitation of forearm rotations. Okay, so when we talk about the compensatory motions, we are also supposed to know what are the functional range of motions in the elbow and the forearm. For functional range of motion, we are talking about the range of motion at the elbow and forearm which is required for day-to-day activities, and that is about 100 degrees of elbow arc, that is 30 to 130 degrees of elbow flexion, as well as 100 degrees of forearm rotations, and that is divided by 50 degrees of pronation and 50 degrees of supination. So as long as we have 100 degrees of elbow flexion as well as 100 degrees of forearm rotations, we will be able to carry out almost all activities of daily living. Okay. Now, in certain studies, it was found out that the more the degree of pronation, the worse is the activity of daily living, the amount of performance with the activity of daily living. Okay, so when we examined children who had more pronation, so that is the blue bar over here. So in the blue bar, the degree of pronation is somewhere about 60 degrees. So with 60 degrees of pronation, a lot of children were not able to do activities of daily living. Okay, So about 50% of the activities of daily living, they were not able to perform. Whereas children who had only about 20 degrees of fixed pronation of the forearm were able to carry out a lot many more activities and were happy with their activities of daily living. Okay, so with this, we would like to conclude that lesser the degree of fixed pronation, lesser will be the disability for these children. Okay, so more it is supinated, the more happier they are. Lesser the flexion, lesser the pronation, the happier they are. More the supination, the happier they are. Okay, so coming to clinical features, the first and foremost clinical feature is that they are not able to rotate the forearm. Okay, 50% of these will be bilaterally involved, but they will be having asymmetrical involvement. Okay, so clinical features of congenital radioulnar synostosis are very variable. They are dependent on the position at which the forearm is pronated or the position at which it is fixed, the stability of the radial head, whether it is in its position within the radial notch or whether it is dislocated, the age of the patient, and whether it's a sporadic case or a syndromic case, which is along with Poland syndrome, etc. Okay, so remember, pathological fusion in severe pronation results in an obvious range of motion limitation. So like we already assumed in the last slide, the more the pronation, the worse the patient is going to be with the activities of daily life. Okay, now coming to the diagnosis, it's often clinical because of the loss of range of motion in the forearm. However, to make a definitive diagnosis, you'd require an X-ray where we will be able to see a fusion of the proximal radius and ulna. Okay, and this will be seen in the proximal 2 to 6 centimeters of the radioulnar joint. Okay, along with this fusion, we will be able to see increased bowing of the radial shaft. Sometimes there will be a hypoplastic radial head or a dislocated radial head. In certain conditions where it's anteriorly dislocated, we might be able to see a mushroom-shaped radial head. And also at the distal radioulnar joint, we may be able to see a dorsal subluxation of the ulna. Okay, so these are the different conditions or the different things we may be able to see in association with congenital radioulnar synostosis. Now coming to classification.